I'm going to spend a little time discussing potential biases inherent in the different data sets and the importance in recognizing them. So while machine learning is exciting, has great potential to improve health, we also have to be conscious of its limitations. In machine learning or any data analysis, it's important to think about the source of the data and the potential biases inherent in it. And I think this came up in a question from the last presentation. And it may seem obvious, but in the world of machine learning, a lot of people think that data is data and more is better. But this can actually amplify biases. And I'm really interested in different sources of biases in data, particularly within EHR records. In order to look at disease at the population level, it's essential to include a study sample representative of the target population. And we learn this in basic epidemiology, but we know this is realistically not always possible. So in this study, we aim to compare longitudinal disease activity between participants in a cohort study and people who elected not to participate, because we had data routinely collected from all of them in a local EHR. And this was specifically in a population of patients with rheumatoid arthritis. And we found substantial differences in longitudinal disease activity between cohort research participants and non-participants, specifically racial ethnic disparities and RA disease activity over time present in non-participants were seen when you look at, if you can see my mouse, when you look at all participants together, but if you looked at just the cohort alone, you could see drastic differences. So we don't see that higher disease activity associated with these different racial groups. So we wondered then if we could correct for these differences since we had information on who the non-participants are. So there are weighting methods such as inverse probability weighting or IPW that have been used to account for non-response bias, relying on correct specification of the selection model. When we attempted to use IPW to adjust for these differences between research participants and non-participants, we found that this was still insufficient to capture the large differences in disease activity by race ethnicity, largely among Black and Latino Hispanic patients. So in the third and fourth columns, you can see here that we're actually moving in the opposite direction that we saw within all participants. And so it really wasn't correcting. And we tried two different corrections. We inverse probability weighted using age, sex, race, ethnicity, disease activity, smoking status, BMI, language, rheumatic disease medication, and total number of visits. Basically, all structured data that we could get our hands on from the EHR. And then in weighted 2 example, the last column, we corrected. In our model, we attempted to correct for everything in weighted 1 and also the proportion of no-show visits, which we thought might be a proxy for likely external social circumstances that might prevent engagement of care, but this had little effect. And so our conclusion was that there are likely additional factors that are not captured in the EHR that explain differences in disease activity between those who participate in a study and those who do not, such as adherence to medications, social determinants of health, things that we couldn't include in the model and are generally not routinely collected in structured EHR fields. Locally at UCSF, we've implemented some changes where we will begin to collect some of these factors in the EHR, and it will be interesting to incorporate them into looking at these two groups down the road. An EHR may have advantages over cohort studies, as I just showed, but they're also not immune to biases. After all, they weren't designed for research. The EHR was built for billing purposes. And so we always have to think about the observed and the unobserved people and data in different study designs. For example, even when the EHR may represent a more real-world population than a cohort study, there are still potential biases inherent in the data. And given recent interest in applying machine learning to EHR data, in this paper, we explored how these algorithms may actually be subject to bias when applied to the data blindly and potentially perpetuate health disparities. And I'll just quickly walk you through this piece. So we discussed three major sources of bias entering EHR data that could have an impact on machine learning algorithms. And it's important to remember that these biases are not unique to machine learning. They actually have an impact on all statistical types of statistical analyses. But today we'll talk about them in the context of machine learning. And they are missing data, sample size, and misclassification or measurement error. Missing data can be thought of as missing individuals in the data set, as well as missing values for individuals in the data set. And machine learning itself cannot assign an outcome to individuals it does not observe, which can really limit generalizability of these algorithms. For example, models trained at an academic center may not directly translate to a community hospital, relating to designing interventions for a population versus a specific group. So we can get erroneous inferences if we try to apply something that was made in one setting and attempt to implement it in a different setting. So for example, patients with lower health literacy may not be able to access online patient portals and document their patient-reported outcomes. And so an algorithm developed to predict patient-reported outcome measures, which tend to be documented by those with higher income, younger age, and white race, may not benefit low-income, minority, or older individuals. Insufficient sample sizes may also lead to erroneous inferences. So models can underestimate values in low sample size categories. So machine learning algorithms will provide mean estimates for these groups to avoid overfitting. And this could result in uninformative predictions for certain subgroups. And therefore, algorithmic benefit may be restricted to larger groups, spurring improvements in certain patient populations without similar support for others. An example of this is when low sample sizes in certain subgroups may be misinterpreted as having a lower disease burden. So we know from the literature that Hispanic children are less likely to receive mental health treatment compared to white and Black children, despite a similar incidence rate. And it would be incorrect for a model to learn that Hispanic children do not benefit from mental health treatment and thus not recommend interventions. So we really have to think about the biases built into these data sets and therefore what the model is going to learn from them. Lastly, with misclassification or measurement error, this can occur with incorrect diagnoses in the EHR, records incorrectly coded, or incorrect patient recall. An example would be uninsured patients receiving substandard medical care more frequently than those with insurance. And so documentation or clinical reasoning will be less accurate or systematically different for those groups. An algorithm may be inaccurate for these uninsured patients and less likely to benefit them just based on this biased input. To wrap up, machine learning is powerful, especially when we have a lot of longitudinal data for prediction and classification. And they're helpful for generating hypotheses, identifying otherwise unknown relationships between variables, and especially when we have different genetic and sociodemographic and clinical variables from the EHR. But they're still subject to statistical bias present in other types of study designs, as well as human biases. And then I'll also add that until social determinants of health are systematically captured in the EHR, we will be missing a significant component in predicting and estimating disease processes. To summarize, today we discussed high-dimensional data and corresponding statistical methods and how they're not immune to bias, and that detailed attention to an acknowledgement of these limitations is really important. And lastly, again, inclusion of factors such as social determinants of health are really essential in understanding complexity of disease.